Let me share. Yes. Okay, great. So as Worsika mentioned, this is our work looking at a mixed methods approach to generate and deliver rapid cycle evaluation feedback. And it's really our methodological lessons learned from a very large multi-center implementation trial in pediatric surgery. And I'll spend some time orienting you to that study because I think it's helpful to have that context before we even get into what the rapid cycle approach is. And so before I get started in that, let me just acknowledge that this work is part of an R01 from NICHD, focused on enhanced recovery after surgery and its implementation in pediatric surgery, and the PI of which is Dr. Raval. He is a mentor of mine. He's also my mentor on my career development award, which is unrelated to this work, but I'd say many of the themes of my work as PI and then also this work as they intersect, and I'll share a little bit about that as well. And of course, this is, we're grateful for that funding, but these are our views, not necessarily views of the NIH. So my goal today to share, as Worsika so kindly introduced me, to share a little bit about me and our team, tell you a little bit about the Enrich Us trial, and then talk more about our publication on the rapid cycle feedback approach that we took, including these implementation report cards, what we did and what we really see as the lessons learned coming out of this. And then really wanted to open it up, as she said, to get your thoughts on this. I consider myself newer to implementation science. I'm learning as well. And so, we carried out this approach because we thought there was a need and we felt like this made sense. And so I'd say that this particular approach was successful, but it's very much tailored to this pediatric surgery context. And so I'm excited to learn more about what others have done in a similar vein in other clinical areas and what lessons learned we can bring back to this clinical specialty, for example. And so, I don't even know if I really need to go over this because there was such a nice overview of me, and I really appreciate that. At Northwestern, and at the VA as well, I characterize myself as a team scientist. I'm a health services and outcomes researcher. I also dedicate some portion of my time to education and mentorship in the health sciences programs here at Northwestern, including those who are, clinical trainees or doctoral or master's students who are learning more about health services and outcomes research or public health, and how to use research to achieve their goals, and explore their research interests more. And so this work, although it's focused on GI surgery, I think it fits well within my overarching mission, which, as Worsika said, is really to help make healthcare better, safer, more coordinated. And I'm expanding that to make it also consider equity in that as well. And it's not just for inflammatory bowel diseases, but also other chronic illnesses. And so this work focused on GI surgery, I think, still fits nicely within that. And I am part of a much larger team, including Dr. Raval, who's the PI of this work. He's sort of the leader of the Enrich Us team. And we're a large multidisciplinary team. This is really just some of us. So I function as a co-I on this work, and there are many others, mentors, students, and other co-investigators who are all supporting this work. And we come from a variety. Some are have clinical background, clinical training, and others are like me, who are coming more from a non-clinical health services perspective. So let's get into what is known about pediatric surgery. I would love to know. Perhaps it's not an easy way for me to ask the audience this, but if you happen to be part of pediatric care or pediatric surgical research, I would love to know that, and just hear more from all of you towards the end when we have our discussion, because I think that there are many lessons learned here that can apply to other clinical areas, although this work is just focused on the unique issues in pediatric surgery. So let's talk a little bit more about pediatric surgery. if you've ever had surgery, if your child has had surgery, or if you know somebody, a child who's had surgery, you know that in the surgical process, there's a whole flurry of activity that needs to happen sort of all at once before and after the surgical procedure itself. And this is sort of a complicated process, including equipment being prepped, patients and families coached, staff briefed, medication administered, all before the procedure even happens. And so into this complicated environment, incorporating new techniques into that process, even when it's something that is well established, something that we already know can improve care, can often be a challenge. And this is particularly noticeable in pediatric surgery when it comes to an intervention known as enhanced recovery protocols, or enhanced recovery after surgery, which represents a short set of very simple procedures performed before, during, and after surgery, which can ultimately help to reduce hospitalization time, reducing cost, and also just improving patients' overall recovery. And I'll tell you more about what these ERPs are exactly and what an example of each of them are in a few slides. This work, ERPs in particular, are very well established in adult surgical literature, where we know that they can help reduce cost, reduce patients' time in the hospital, and also enhance their recovery, getting them back on their feet quicker. But for pediatric surgical centers, there's been a particular lag in how that intervention is put into practice. And we all know this, I'm sure this is no surprise to the audience here. It can take up to 17 years, maybe sometimes more, for patients to see the benefit and for that science to be incorporated and translated into practice. And when we think about pediatric surgery in particular, this is a complicated, complex area of clinical care. Children represent a very heterogeneous, diverse population with age-specific needs. We're talking, 0 to 18. There's such a wide variety of needs there, and that all of pediatric surgery needs to account for sort of all at once. And those complexities within the pediatric age have not always been accounted for very well in new strategies to improve the delivery of surgical care and subsequent outcomes. And so that's sort of been a barrier for some pediatric surgeons and surgical teams to take up new interventions like enhanced recovery protocols. And that is sort of compounded by the fact that some surgeons, as in other clinical specialties, some surgeons also simply resist altering long-standing practices, feeling that their clinical specialty has sort of been, cut off from other areas of medicine or other areas of surgery. And so it's hard for them to sort of take up those interventions. And this is in part due to misperceptions about what the intervention is. It can also be a product of lack of knowledge about current research evidence to supporting that intervention. And so the ENRICH-US trial stands for Enhanced Recovery in Children Undergoing Surgery. And that addressing those issues is really the goal of this work. This is a prospective, pragmatic, multi-center implementation trial in which our goal is really to evaluate the effect of an evidence-based ERP, which is already well established in the adult literature, as we know, and understanding how we can adapt it specifically for children undergoing elective gastrointestinal surgery. And the thing to remember here is that enhanced recovery, this intervention, is really a proxy for trying to get better sooner and get patients on their feet quicker after surgery. And I don't want to belabor the details, but I think some of this context is actually relevant as we start to think about our, rapid evaluation format. This is, for those who are familiar with, these implementation trials, which I'm sure everyone in this audience is, this is a type 2 hybrid stepped wedge cluster randomized study with 3 clusters of 6 pediatric centers each. So 18 pediatric surgical centers across the nation in total. And the type 2 study design is really indicative of our dual focus on not just the clinical effectiveness of what happens when we put ERPs into practice, does that improve clinical outcomes, but also this the secondary focus in parallel on implementation outcomes, particularly adoption, fidelity, and sustainability of this intervention. The clinical outcome, as I mentioned here in the third bullet, clinical outcome that we're most focused on is length of hospital stay. So if we get these ERPs into practice, do we ultimately reduce length of hospital stay for these children undergoing surgery? And then again, that dual focus on the implementation outcomes. And so we at Northwestern, we represent the coordinating center of this entire trial. And to support team engagement at each center, we have sort of a site principal investigator, oftentimes a surgeon scientist, and we have research coordinators and a whole multidisciplinary team really at each center. And we're sort of the central area where we're coordinating among all the 18 sites. Center implementation teams participate in monthly ERP learning collaborative sessions during their 12-month implementation period. And these learning collaboratives are really focused on offering centers practical guidance and benchmarking of implementation milestones, in addition to providing center-specific quarterly data reports, tracking their compliance, the patient-level enhanced recovery protocols, and then sort of benchmarking against peer performance to say how are sites in cluster A, cluster 1 doing against each other, really, and sort of using that to foster hopefully some iterative improvements as well. And so at each center there is an implementation team, which usually consists of different individuals like this. Oftentimes there's a surgeon champion, who I mentioned is usually the site PI. There's often an anesthesia champion, a patient advocate liaison, a quality improvement professional, a data abstractor, and research coordinator oftentimes. And this can look a little bit different from center to center, particularly since we have, such a wide variety of different surgical centers. And some are just happen to be more higher volume, and they have a big clinical team, so they could have a robust implementation team like this. Others have a much smaller, lean operation. And so for each of these, for the implementation teams at each center, we have sort of delineated what the team roles should look like for the surgeon champion, patient advocates, and so on and so forth. And I won't get into the details of this because this is fascinating in itself, but a little bit less relevant to the report card work. But what I would say is that you can imagine that at each of the 18 sites, they have some combination of these individuals comprising their implementation team, and those teams all come together in these monthly collaboratives, and they work with us as the coordinating center. And again, this is all meant to sort of go back to solving that initial issue, which is that strong research evidence can oftentimes take up to 2 decades to get from bench to bedside, and this is a particularly troublesome issue for pediatric surgery, which is a smaller segment of surgery, where the uptake of evidence-based interventions has been even slower than other areas of surgery. And so what is an enhanced recovery protocol? So I mentioned that we're focusing on implementation of the ERP in addition to the clinical effectiveness of getting that into practice. So what are they? This graphic is really is the entire bundle, and they represent different practices that are done at every stage of the perioperative process. So pre-admission, before the surgery happens, preoperative, right before the surgery happens, intraoperative in the blue, and then in the purple, the postoperative period. So the entire ERP bundle comprises this entire timeline. And so let me give you an example. In the pre-admission group of ERPs, we have one that is setting patient family expectations, and that can be just as simple as having, allocating some time for, to be more intentional about aligning, the child, patient, and their family's expectations about the surgical process and what they can expect at what time, with respect to the surgery happening, what steps will be taken in that process, and then finally what their recovery might look like. It's just trying to be more deliberate about that going into the surgery. In the preoperative, an example of an ERP might be starting non-opioid or non-narcotic analgesic medications. The evidence from the literature here suggests that when we give patients more opioids, that can prolong their recovery after surgery. And so getting started even before the surgery starts with non-opioid medications, including things as simple as Tylenol, paracetamol, or gabapentin, for example, can kick things off on the right foot, where we're not using too many opioids, and we're hopefully optimizing their recovery afterwards and minimizing their pain. On the intraoperative side, like within the surgery itself, an example, there's so many examples of each of these columns. For the intraoperative side, this could be, this is a good example of where minimally invasive surgical techniques can really help optimize that recovery period. It's particularly for children, right? Where we think about explaining to them that, hey, we're going to make smaller cuts when we do the surgery, and that can help you get back on your feet quicker. And on the postoperative side, if anybody who's had surgery, more recently, you may recall, or if your child has had surgery, you may recall that there's a lot more encouragement to get on your feet physically quicker after surgery now. Oftentimes within a day of even a major surgery, oftentimes there's emphasis on standing up, moving around, ambulating more quickly, which is associated with benefits and just improving your recovery overall and having just a longer term improvement in your recovery. So as you can see, they're all relatively individually perhaps simple. But of course, we work in implementation science, and we know that it's really, the challenge really becomes when we start to think of them as a bundle. And we're trying to implement the combination of ERPs. That is what becomes more complicated and requires sort of this contextually adapted, coordinated effort across all of the care teams at each stage of surgery. And so that's where I think some of the nuances come out and what implementation is looking like at each site. And so just for a little bit more context for the EnrichUS trial, as I mentioned, there are 18 sites. Number 9, we're here in the star. That's us, Northwestern, the coordinating center. And we've included pediatric surgery centers across the country. And this is very intentional, not just because that helps us in achieving our sample size goals for, gathering a cohort of children undergoing gastrointestinal surgery, but it also gives us variation in the types of centers and what their characteristics are like when we think about implementation, what their unique challenges are. And then I mentioned that this is a stepped wedge design. So because we had the 3 clusters, we could sort of stagger when everybody started into their, started with the control phase, and then we sort of went in this stepped wedge pattern in which each site had, each cluster had a 12-month implementation or intervention phase, followed by the sustainability phase. And at this point in the study, we're getting towards the end, so we're more in the sustainability phase for all clusters, but we're still actively collecting data and working with sites and seeing how things are going for them. And there's just so much detail to explain about this study, and I don't want to belabor it too much because I want to keep more focused on the report cards and the rapid cycle feedback. But if you are interested in learning more about the EnrichUS trial, it's really a big effort. I think the best place to go to learn more about our overall methodological approach is the study protocol paper led by Dr. Raval. But there's, this work is really building on, a small but robust growing literature that our team has really been actively working on for several years now. And so let's zoom in more into our rapid cycle approach for this study. I'd say that, this is, again, as Borsika mentioned, this is a recent publication that we had in Implementation Science Communications. And overarching goals here were for us to understand in pediatric surgery how we can think about speeding up evaluation of bundled interventions such as ERPs implemented across multiple facilities. And then two, to understand how we need to deliver that evaluation feedback in a way that is clinician facing or implementation team facing, so that we can iteratively promote improvements to implementation. And this is something that really has not been explored in pediatric surgery to our knowledge. And so would love to chat more if others have thoughts about this, or even from other clinical areas that might be relevant. And I'd say overarchingly, some of the key themes or attributes that I see coming out of this work that are really relevant outside of pediatric surgery even are that, we had this strong focus on delivering timely and constructive feedback, really focused on collaborating within our team to get this evaluation process going, and then also working directly with the pediatric surgery centers and their implementation teams to facilitate this process, to create and deliver the feedback using our report cards, and then ultimately to improve surgical care for children undergoing surgery. And when you have this broader enrich us context in the background, then we can start to think about like what our issue really was. Why was the need for this process even needed? And it's really because we started with a problem. We know, as researchers at Enrich Us, our goal is to improve surgical care for kids having GI surgery. And all the pediatric surgery centers are working on implementing the enhanced recovery protocol. And from that, we can learn many valuable insights when we evaluate how that implementation process goes for each center. Those are also insights that the individual centers and us as the coordinating center can also benefit from. So there's really a lot of value in those evaluations, but as we all know, evaluating implementation traditionally can take a really long time, and that's where we struggled, because if our evaluation is going to take more than a year, for example, using our conceptual frameworks and our large team to make sense of how implementation went for each center, and then distilling down our lessons learned and then sharing that with sites, it can just take it can take a long time. Our thought was that centers may simply benefit from more timely information on what's going on now, what's going well, and what can be better in a more real-time format. So the question we started with was, how could we support these pediatric surgery centers with quick practical feedback to promote iterative improvements as we get enhanced recovery protocols into practice? And our view was simple. What if we could have a system in which we, use a mixed methods approach, conduct a site survey, follow that up with qualitative work, including interviews and focus groups, use that to foster team-based evaluation, develop the report card as a team, and then share that report card with the center, sort of almost like in a learning health system format, but something that was just adapted for the needs of our study. And that's really the heart of this paper. For this study in particular, our aim was to use a mixed method sequential explanatory approach in which we collect the quantitative data and then use that to inform our qualitative data collection. And I'll share more about that approach in another slide or so. And we, we had to improvise. There wasn't really anything in pediatric surgery. There's very little at the intersection of pediatric surgery and implementation science to begin with. So to ask the question of what has been done in, rapid cycle feedback in pediatric surgery, there was just nothing there. And so we leaned in to what we could find in other disciplines, including higher education and engineering. And the concept is actually something that we can likely all relate to. For example, in school, when we get a report card, and that's meant to tell us how are things going right now, how can we improve, to foster changes that can improve your grade, for example. So that's kind of just the heart of the concept that we were thinking about. And we had to look in other disciplines for that. Our goal was really to triangulate that quantitative and qualitative data to generate center-specific implementation report cards. And then thinking back to what I was saying earlier about making sure that this was acknowledging that this, any report card that we create needed to in a format that could be understood and made sense for those who are implementing it. So including the surgeon champions and others on their center implementation team. In that, trying to address that, we decided to use this traffic light framework to quickly visualize implementation status, strengths, and opportunities for improvement. And so here's like a little closer look at our approach. So Enrich Us, as I mentioned, just about the broader study. Part of Enrich Us already involves the creation of these center-wide implementation teams, monthly learning collaboratives to establish key milestones, particularly from an implementation standpoint. And as part of the broader trial, we already share with every center their quarterly patient-level data reports, and an overview of their ERP compliance. And so our approach, coming back to that cycle, was what if we, there's a 12-month implementation period. What if at the 6 and 12 months, us as the coordinating team could carry out that cycle of site surveys, followed up by qualitative interviews or focus groups, and then have that team-based discussion and evaluation to develop the report card, and then quickly share it with the sites, with the individual centers, excuse me. And our thought was that this, going through this process would hopefully enhance, the engagement that we saw at across center implementation teams. Hopefully this would promote sort of iterative changes as people read their report cards, and try to think about what adjustments they might want to make to implementation at their own center. And then hopefully that would increase the uptake of the intervention itself, and hopefully improve adoption and fidelity of the ERP itself. And then ultimately, our hypothesis that this would support sustained ERP use, and then help achieve our overall clinical outcome of interest, which is to reduce length of stay for these children undergoing GI surgery. And so that's sort of our broader approach. In the longer term outcomes, I wouldn't say that we've gotten quite as far to really establish that those are the outcomes that we have seen. But that's certainly our goal, and something that we will be working on. So the mixed method sequential design, in this approach, we first use the quantitative site surveys, which is a very brief 15 question survey administered at the 6-month and then again at the 12-month mark, following the center's implementation period. And those surveys focused on, our sample was, the site PIs, and other representatives of the center implementation team. The purpose here was really to gain understanding of that center's ongoing progress, the extent of their implementation of the ERP, and also for us to gain sort of a baseline understanding of what are the key strengths and weaknesses for this center with respect to their implementation process. In the qualitative side, we immediately after the site surveys, we used that to inform our interviews and focus groups, which included in-depth, semi-structured interviews or focus groups in cases where, you know, we were meeting with us, you know, the site PI, and then they also wanted to include other members of their implementation team as well. And that was conducted to follow up on the site survey results, again at the 6-month and the 12-month mark following the start of their implementation period. And for that, the sample was similar. Members of each center's implementation team, including, you know, for example, pediatric surgeons, anesthesiologists, other clinical team members at that center. And the goal here was, as I'm sure is no surprise to folks on this call, the goal here was to really dig deeper into the site survey results to gain an understanding of, you know, underlying factors that might be shaping the center's implementation process, challenges and facilitators that they might be experiencing, and also to identify opportunities for improvement from the perspective of the center's own implementation team. And so for this process, I think, you know, it was helpful for us to just be intentional about what is our process, because we have a large qualitative team that's focusing on the implementation within the Enrich-Us trial. But this was a little bit different and really sort of signified that there's a mindset shift almost in doing a more rapid approach. And so we thought that it was helpful just to lay it out a little bit more clearly and see how it sort of compares and contrasts with our general qualitative or mixed methods approach to the data that we had. So in this case, our 5-step process was to first clarify the intended action plan. Our goal was first to identify who among our coordinating team would be involved with the feedback process. We aligned on what the purpose and the protocol was for us to generate and deliver this rapid feedback. We drafted a 1-page implementation report card template and what fields this should include, and I'll share more of that in like the next slide. We also had to spend a little bit of time aligning on who is the target audience for the report cards. Because so much of what we were doing on the research side was, I think, just preparing for us to learn about how implementation was going and have that translated into, you know, peer-reviewed publications later on. But that's different. That's different than having something that is, you know, center-facing and something that the sites themselves can take home. And hopefully use that to iterate on their implementation efforts. Step two, I think was a big change for us. Collect good enough data. You know, we have in the Enrich-Us study, we have, you know, we're using the PRISM and RE-AIM frameworks for our broader, more traditional implementation evaluation. But this is not that. This is outside of that scope. In this case, we're really looking to just understand what are the low-cost data collection strategies that we can do in a timely manner, and what can we do in a format that we can support quick data collection with note-taking, no transcripts or detailed coding or anything like that. So we really had to be very targeted and just list out what the key questions are that needed to be addressed in data collection so that they can ultimately populate the report card fields that we had. Step 3 here was engaging in that team-based evaluation discussion. So as a team, we would engage in reflective discussion and really focus in on 3 main questions, which I think of as the what, so what, and what now. What are we learning about with respect to this center's efforts to implement the intervention or ERPs? For this center, what are the likely implications, of our findings? Will this lead to changes, or what sort of changes will that lead to? And what now? What actions are required to improve implementation moving forward, starting today? Our goal was to come up with results and create an implementation report card that was actionable, that should allow the center almost immediately to sort of adjust their implementation efforts moving forward. Step 4, developing the implementation report card. As data was collected, we were working on interpreting it using our team-based discussion format. And then we would draft out the center report card that in a way that just highlighted the major findings only. We wanted, again, thinking about the format and making sure that this was appealing and something that was digestible by individual center implementation centers. We wanted to make sure this was visually appealing and also just easy to understand. And our goal was to share the completed implementation report card with each other. And then very quickly, and by quickly, I mean within 10 days after the qualitative and quantitative data were collected, share the report cards with the implementation team, including their site PI. And so this is what we had drafted, and this is what we've been currently using as our implementation report card template. And I mean, I think there were some examples in the literature of other implementation report cards using some similar rapid cycle formats. But we really just designed this to be what made sense for this study. A site would need to know, we just envisioned that if you're a busy pediatric surgeon who is involved in this study and you're leading the implementation efforts at your center, what are the things you need to know? We wanted this to absolutely be on one page. They need to know their site name, which cluster they're in, what is the date of this, and then sort of that overall summary. And then very quickly, the bullets in the middle indicating where they're doing a great job, where they could improve a little bit, or where are some areas where they really need a lot of improvement. We also tried to be intentional about this notes area right at the bottom. Again, keeping in mind that there may be a very busy surgeon, PI, or anesthesiologist who is looking at this, and they simply don't have time. So just to address, what am I looking at right now? Why does this matter? We wanted to make that very clear to them on this one pager. Here's an example of sort of a completed report card, a good one. Completed report card in which we've redacted some of the identifiable information. And so we go through our process, as I mentioned, with collecting the data, making sense of it in a very quick way, and then populating this report card, making sure that the whole team is sort of aligned on what the key messages are of the report card, and then sending it out to the center implementation team. And so here, I'll just walk you through some of the some of the key points that I think are helpful to see as examples. So in the summary section here, we had just our overall take on what we were seeing in the site survey, and then the follow-up qualitative work, and then what we really reflected on as a team after that, looking at that data. Here it says for this center, despite a site PI change, the team and the site PI have done an excellent job of implementing enhanced recovery protocol elements. The site continues to hold monthly team meetings and has created several tools, including badge buddies, that help communicate ERP and surgical site infection elements to residents and trainees. So that's sort of an example of just the quick summary of what they might see. And as you can see in the implementation status details in the middle, there isn't a whole lot more detail in there. It's meant to be very quick. And again, it's really meant to be a platform for initial discussion. If the center wanted to discuss more or wanted to dig in more onto their yellow area, the bullet points under the yellow area, they could do that. This is really just a starting point, hopefully a catalyst for more discussion and iterative improvement. But we've heard back from sites that they've reflected on these, and for some who have gotten yellows or reds, it kind of stung a little bit, and so I think that has achieved some purpose in hopefully fostering some positive change. And I would say I'll try to wrap this up quickly so that we have a little bit of time for discussion. We walked away with several lessons learned, and I'll walk through them quickly. I'll group those according to what we see as potential benefits, some potential challenges, and then some practical considerations. So among the potential benefits, I would see going through this approach, we thought it was very helpful in quickly understanding variation and implementation and corresponding needs across centers. I mean, with 18 sites across the country, the makeup of each one and how what their implementation efforts look like just inherently differ significantly. And so going through this report card process in a relatively efficient manner could help us just identifying that variation and sort of understanding which centers need a little bit more support, where do we need more engagement, and targeting our own efforts really moving forward. That was helpful. I think it was also helpful in having a touch point where we could provide actionable feedback efficiently to centers about their implementation, rather than going back to them, 18 months later and saying that this is a result of our implementation evaluation using the PRISM framework, for example, which is extremely beneficial. But when centers need information now, actionable feedback now, then this was a way to foster that. In our view, I thought it also helped in facilitating some partnerships with the centers through our mixed method data collection. We went through each step of the data collection with the centers, and there was this acknowledgement that we're working towards developing this implementation report card for the center. And so I think that created a little bit more of an intentional platform to have those discussions and to foster a little bit of partnerships. Borsika?
Salva, this is so wonderful. We are getting all this very positive feedback. We have about 11 minutes. I just wanted to give you that timing. And we are receiving some questions in the chat. So I just wanted you to kind of decide on how you want to manage the rest of the time. But we do have some questions coming in.
Okay, I will, if you don't mind, I'll just go through just this slide and then maybe just the take-home points, and then I'll just open it up for discussion.
Perfect.
Does that sound okay?
Sounds great. That sounds great.
Thank you so much. I'm sorry for going. There's just so much to share.
It's wonderful.
I appreciate it. Thank you. So I think potential challenges, and this, I think, whether or not it's a challenge, I think is a little bit based on perspective. But I think for us, coming from, a more traditional qualitative or traditional mixed methods approach, I think what stood out to us was that even though this is a somewhat rapid approach, within 10 days, of data collection, we have processed and made sense of this data and then sent it out to the centers. It still required substantial amount of resources. And so we still needed a lot of time, personnel support, person hours, all of that. We still needed to bake that in, even in the rapid format. And so I think that was important. And I think too, we're not using a conceptual framework in this approach, trying not to belabor, those aspects of qualitative research and bake that in here. We really focus more on timeliness, but still I think to enhance rigor, having that consensus among our team was really critical. And so that was something that, we sort of underestimated. And so we thought of it as a challenge, but it may not be. Practical considerations, I think, again, coming back to this mindset shift of this is not traditional qualitative or mixed methods work. We're really focusing on timeliness of rapid feedback versus its comprehensiveness. And you can sacrifice something there potentially in the name of getting information out quickly. I think having actively engaged members of each center's implementation team is really critical here, including the whole gamut of those who are on the implementation team. And then finally, I think having an iterative, reflexive approach to your rapid cycle format, I think was really important for us. And we had to tweak things along the way, and we will continue to do that. So we're continuing to use these. We've rolled them out, and it's been going well. We've been giving them to all sites, and so far so good. We've gotten some positive feedback. I think for us, as for me as a non-clinician, also someone who's worked on QI, I think this work really highlighted to me that nexus between implementation science and healthcare quality improvement, particularly in QI is focused on driving system level change through evaluation and continuous improvement. So I think this was like a really cool way to highlight that overlap. And so, for us, I'll stop here. I think, take-home points are really that, this was a positive experience for us in which we could provide constructive, timely information to centers about their implementation. I don't think this can substitute traditional implementation evaluations, but it can certainly complement them depending on the needs of the study. And I think for us, open question is that whether this approach actually enhances the uptake of ERPs longer term continues to be a question. Thank you so much. There's so much more to share, but I will stop here. I really appreciate it.
Thank you so much, Salva. Well, you don't need your questions because I have many for you from the chat, if it's okay. And I think Russ and I have to
Please.
hold back on ours. So I'm going to start here and pull in a few, if I may. Let me start with Julie Kakichi's question. Julie, do you want to just say it?
Sure. Yeah. Sorry. Hi. Really great presentation, amazing study. And I was just curious how your team balanced, or if you were able to balance providing site-specific feedback with maybe sharing best practices and or adaptations from the other sites, given that it was a multi-site study, and managing to do that in quote real time.
Yeah, it's a great question. And again, something that we had to be intentional about with such a big study and just so many insights from a center specific level and then more broadly. I think for us, that question was made a little bit easier with the learning collaboratives already in place, where that was a place where, for example, an entire cluster would get together for their monthly meeting, and each, it was like a 12-month series for the learning collaborative of, every month, a learning collaborative session. That's where we could really focus on, hey, today's session is only focused on, how all of the sites are doing as a cluster and who's sort of lagging behind, that sort of thing. And then we would spend time outside of that with giving people their quarterly reports on how their compliance was looking at a patient level at their center, and sort of benchmarking a little bit if needed with other sites. And then the report cards were really meant to just be very center specific, because we thought that that's what seeing things in aggregate at that point may be less helpful for the center, and it should be more about what's going well or what's not going so well at your center. Does that answer your question?
Yes, it does. Thank you.
Thank you.
Wonderful. I'm going to read some of the others because of time, but we really appreciate the very active chat. And please feel free you don't have time for that, Salva, but we can save this and you can look at it later. So Mohammed mentions a question about what kind of theoretical underpinnings did you use, explicit or implicit, and how you expected the report card will bring about positive change?
It's a good question. Again, and I'm happy to share with the group, some of the literature that we used in the paper to really just create our format. And I teach research methods to graduate students now, and I teach them about conceptual frameworks. And what I showed you in the, our framework for this study, to me, I don't even look at that as a conceptual framework, because it wasn't really, showing the visual relationship between different scientific constructs. It was more about this process. And so that, what our steps were, and that, I would say, Mohammed, we borrowed that from other disciplines even. I think there was something around rapid cycle, one particular study, I think that was focused on higher education and rapid cycle feedback. And they had something similar, which we said, hey, we can take that and adapt it for this clinical setting. And it could make sense. And again, this was, Dr. Ravel coming to me and saying, Salva, we need a one-pager kick in the butt for some of these sites that are just not focusing their implementation efforts where they need to be. So I'd say like that, the theoretical underpinnings are maybe less present because we simply did not use the traditional conceptual frameworks we're using in the study, but we leaned in more into what is the process used in other similar studies in different areas, and really use that to build our rigor a little bit. Does that answer your question?
I think it will have to do, because I'm going to go to the next one. This was wonderful. It sounded great to me. Thank you. Greg Ahrens mentioned a couple of things. Greg, if you have any publications you want to recommend in terms of looking at champions' knowledge, skills, and abilities to consider that, please drop that in. But Greg also asked about ad hoc adaptations, and how did you document those and integrated that into the protocol, if you did?
No, it's a good question. We did not, I wouldn't say that we wouldn't say that we changed the protocol as we went along this process, because we still have like I guess protocol for the feedback process as opposed to protocol for the intervention itself. That didn't change. But this process of like how we carried out the rapid feedback process, like that protocol may have changed a little bit. For example, initially we had thought that, one team member could, populate the implementation report card and then share it with the rest of the team. I think later on in the process, we said, no, 2 team members who were involved in the data collection, they should really work on it together. And then we have a broader discussion with the team. So like in that sense, we made some ad hoc adaptations, but I mean, it's fast. Like if you have to get something out within 10 days, then I think getting together a large team, and we have more than 10 people on the team, really, I'd call that ad hoc.
Well, Salva, thank you for that, and your presentation. It's wonderful. My question was in reference to things that the people in the healthcare workplace adapt ad hoc that you may not have planned, and how do you capture those and integrate things that could improve the process?
It's a good question. I can't say that I have an answer for that just yet, but I think that's absolutely something that's on our mind, and to see what the feedback was like and what the impact of something like this is certainly something that we will focus on.
Thank you so much. I'm going to squeeze in one more, perhaps. I'm trying to pick. I'm going to say there is one question about, would you think that this rapid cycle feedback could be applied to the implementation of screening and referral for household food insecurity in obstetrician and pediatric clinics?
I'm certainly not an expert in that area, but I mean, I think at the heart of it, this is a versatile approach that can be used in so many clinical specialties, and many of which, have struggled with implementation of evidence-based interventions. So I think that it absolutely can be. And if it would be helpful, I'm happy to chat one-on-one with anybody if they would like to learn more, or if you'd like to see if I can help you thinking through an approach for your study. Happy to do that.
Wonderful. I left out a few comments. I apologize to those who asked them, but I would say that we are so grateful, Salva. You can tell that this was very popular and very well received. We are very grateful to have heard about it. If someone wants to contact you via email, would that be okay after?
Of course.
Okay. Would you mind to drop it into the chat? And
yes.
Thank you so much, everyone, for being here and being so active on chat and asking questions. Fantastic presentation, and I will look forward to seeing you all in November with Alvin's presentation, and have a wonderful rest of your October. Almost done there.
Thank you so much. Thank you all.
Thank you.
Appreciate it.
Bye-bye.
Thanks for the invitation.
Thank you. Bye.